Hello future nurses, welcome back to Easy Nurse, where nursing education made easy. So today again we came here with the midwifery and gynecology live. So let's start about the today's live session. So mainly in this session we are going to discuss regarding the pregnancy and then physiological changes based on the each and every system of the maternal body. Okay, so first you have to know what you mean by the pregnancy or what is the definitions of the pregnancy. So pregnancy, this term, it's mainly used to describe the period in which a fetus develops inside of the woman's womb, and by the mitosis, meiosis as well as the cell divisions, how much cell division is growing up, and based on that when this fetal process as well as circulation process, heartbeat, everything is developing inside of the mother's womb, especially in the uterus. So this journey is known as a pregnancy. So mainly it's completed after the delivery of the a term body from the inside of the uterus to the outside of the uterine world. So it takes around the 40 weeks or the 9 months. So it's nothing but it's a continuous systematic process which begins after the implantations of the zygote in the myometrium layer of the uterus, and it ends after the delivery of the term baby or the viable product of conception like fetus, placenta and membranes all together. So it takes around the 40 weeks or 9 months. So now come to the systematic process is having a 3 phase or 3 trimester. So first trimester is known as from the 0 month to 3 months. So first 3 months is known as a first trimester. Second trimester from 3 months to 6 months, and then third trimester from 6 months to 9 months. So now come to the preconception care. So what do you mean by the preconception care? Preconception care is nothing but it's a difference to health and then the health of a child. So make a difference between the maternal health or the physiological health and compared with the child health. So it's very popular to seek the information and health care which is mainly happening priorly to conceive the pregnancy. So suppose as example, if the parents, anyone is having any kind of the genetic disorder, okay, so after conceiving the pregnancy, whether there is a chance to get that same disorder for that baby or not, so to propose this kind of the information before conceiving is known as a preconception care. So this information which mainly helpful to prepare the normal parenthood, means who is going to be parenthood. So for them it's very helpful to prepare as the physically as well as psychologically. So now come to the definition of preconception care. It's a very positive step forward which is enhancing the pregnancy outcome and provide the prospective parents with opinion that may not be available once pregnancy is confirmed. So as I said, like a genetic disorder or thalassemia. So if any one of the parents is having the thalassemia or is their carrier of that particular thalassemia gene, so after conceiving, if they already conceived, so that time there should be no chance to give that kind of information. The baby might be getting this thalassemia, right? So before getting this conceiving or before conceiving the pregnancy, we have to give that information. What might be happen? How much percentage is there to get the thalassemia of the baby? So this kind of information or this kind of the like starting is known as a preconception care. So see the aims. First is the secure optimal health nutrition conditions for both the parents. Next one is ensure the optimal state of mental and physical health issues for both parents. Third aim is assess the normal health condition for the childbearing woman. So whether this woman is healthy for childbearing or not, whether the mother is having any kind of the genetic disorder or any kind of the chromosomal disorder or sexual disorder or not, which will be affected for during the conceiving time. So these kind of things we have to assess. Next is promote the prenatal health, and last one is provide the benefit for being the treated high risk causes of the pregnancy, like as example hypertension, gestational hypertension or gestational diabetes mellitus, etc. Okay. Now come to the purpose. So what is the purpose? First is establish the lifestyle behavior. So due to this the lifestyle, if it's going to be affected during the conceiving of the pregnancy time, so at that time we have to give a proper education to the parent, to that particular parent, to maintain the lifestyle properly, which will be helpful to promote their pregnancy journey. Next one is identify and treat the risk factor. Means what are the risk factor is present to get any kind of the chronic disease or any kind of the complication. As example, like during first stage, like bleeding. Okay, so if there is a bleeding is present, means immediately they have to concern with the doctor. Otherwise there is a chance to get miscarriage as well as any other complication. As example, placenta previa or abruptio placenta, as well as a ectopic pregnancy. So if any kind of the risk factor or if any kind of the complication if they're seeing, means immediately they have to come to doctors. Next is conceiving the pregnancy without risk factor, and last is prepare the people psychologically for the pregnancy, because when after conceiving pregnancy, especially after delivering the birth of the baby, they can't able to accept that baby inside of that. Okay, so that time they are not treating the baby properly, so it will be very harmful for the baby. So before conceiving only we have to prepare those particular parents in a psychologically. So these all are the purposes. Now come to the components. So what are the components? First is health promotion, second is the risk factor assessment. These all are the main two components. So under the health promotion, one of the most important component, that is nutrition during the pregnancy. Proper amount of the carbohydrate, proper amount of the fat, protein, everything, it need to be given to the mother. Next one is the exercise and rest. They have to do the exercise. As example, the tailor sitting exercise, which will be helpful to tightening the pelvic floor muscles, as well as the exercise like a birth ball exercise, which will be helpful to descend down the baby, and it's also helpful for the normal vaginal delivery. Next one is the use of the safe sex practice, means by using the condoms as well as any other kind of the barrier method. Next is the under this nutrition, that is healthy diet. Okay, so you just remind, after conceiving the pregnancy you have to increase, means the mothers have to increase greater than 11 kg, up to 11 kg or greater than 11 kg, like in the term phase of time, which should be which was like previous weight, previous pregnancy weight. So more than that 11 kg they have to gain up. Okay, so next is the optimal weight. As I said, like fluid and electrolyte imbalance as well as the weight management is most important. So under this risk factor assessment, first is the medical history, past medical history as well as the present medical history. Then reproductive history, if any previous miscarriage is present or not, previous any kind of surgery is happened or not in the reproductive tract or reproductive organ of that mother, so that we have to check. Next is the environmental condition, and next is physical examination, laboratory studies, which will be helpful to assess the general condition. So under this medical history, immune status also we have to check whether the mother is taking this immunization, that is TT1 and TT2. So tetanus toxoid 1 and tetanus toxoid 2. Next is the illness as well as the genetic factors or disorder, if it is present for the mother as well as their family. Next is the current use of the medication as well as the medical condition. Medication we have to know, because if they're using currently in medication, whether it will be affected, whether it's crossing the placental barrier or not, everything we have to check. Next one is the age, lifestyle and stress. Okay, so now come to the preconception care for the man. So preconception care is not only for the woman, it's available for men also. First is the stop smoking. This is one of the most important care under this preconceptional period. Next one is the limited use of the mobile phones. Why? Because if you are keeping this mobile phone inside of the near the genital area pocket, so what will happen? Through the radiation of this the mobile phone, it's decreasing the sperm count. So due to this decreasing of sperm count, the man is not able to produce the healthy sperm during the sexual intercourse, so which will be impacting the pregnancy journey and for the baby also. So that's why you have to limit the use of the mobile phone during while you are planning for the conceiving. Next, avoid the increased temperature around the genitalia. Always we have to give the information to the men, like always using the very loose type of the cloths, especially in the night time or sleeping time. So what will be helpful? The blood circulation will be proper in that proper genital area, so the sperm count and then the maturation of the sperm will be proper for the man. Next is the cutback on caffeine, because if you are having excessive or consuming excessive amount of the caffeine means the hormonal imbalance should be happen inside the circulatory system of the father, so which will be impact on the sperm which will be impact on the sperm production. Okay, next is the avoid medicine that impact the fertility and sex drive. Next is inculcate their relaxing schedule. Next is the stop alcohol or any kind of the steroids. Maintain the healthy weight. Next, plan for the finance, like financially the father have to be stable, because after the conceiving of pregnancy there are so many process are there which is needed money. So that's why financial stability is one of the most important thing. And last is think about parenting. So these all are the preconception care steps for the men. Now come to the genetic counseling. So genetic counseling is nothing but it's defined as a process of communication and education for the parents that addresses the concern relation to the development and or transmission of the hereditary disorder. So through this genetic counseling, the counselor, they are mainly giving the example of the hereditary disorder, sexual disorder or chromosomal disorder, which might be there is a chance to transfer from the parents to the particular baby. So that is called genetic counseling. So now come to the objective. First is to help the individual and family. Next one is provide the accurate information regarding the risk factor. Next is reduce the number of the hereditary affected children, and last one is support the people who already affected with the inherited disorder. So now come to the types of genetic counseling. First is the prospective counseling. So prospective counseling is nothing but like before conceiving of the pregnancy, we have to give the proper counseling to the parents by knowing their present and past medical, surgical as well as any kind of the obstetrical history, there any genetic disorder if it is present inside of the family history or not. So these kind of counseling we have to provide after taking all the history. Okay, next one is the retrospective counseling. Retrospective counseling is nothing but like from the family we are collecting all the data, and based on that we are giving the education to the family members. If they are planning or some couple are planning to bring the children in that family, means what should be the impact for the children. So these kind of the retrospective counseling. Next one is the expanded family genetic counseling, like from the family how it's going to be expanded to the second generation, to the third generation. So this counseling or this studies is known as a expanded family genetic counseling. Now come to the steps of genetic counseling. First is the diagnosis. How we are going to diagnose? By taking the history collection, collecting the data. Next one is the prognosis. So after collection all the data, you have to go for the dissemination. So when you are going for the dissemination of the data, so that time you can understood how the particular disease is going through in that particular family members. Okay, so that process you came to know, that is called prognosis. And after this prognosis, treatment, how you can manage that particular pathway of to spread of the disease from one generation to another generation. So that is called treatment. And last is the inheritance and recurrence risk, like what are the genetics or what are the genes or what are the coagulation factor or what are the genetic factors are involved in that particular disease progress. That is called inheritance. And recurrence risk means what are the which group of the people at what age time they the baby will get that particular disease condition, means there is a chance to get that particular disease condition. So that and all we have to check it. And last is the genetic testing. So now come to the maternal physiological changes during pregnancy. So during the pregnancy, due to this hormonal changes, the physiological changes are happening for each and every system of our body. So first is the gastrointestinal system, reproductive system, integumentary system, circulatory system, respiratory system, body weight, urinary system, skeletal system, and last one is the endocrine system. So for each and every system of our body is going to be changes during pregnancy time. So one by one we will see. First come to the reproductive system. So first is the external reproductive system. So external reproductive system we know it's all known as a vulva. So vulva it's become as a odematous, means edema type of formation, hyperemic, like blood circulation is excessively progressing in that particular area. Then superficial, you can palpate on that particular area, as well as a varicositis, especially for the multipara, means who already give the birth previously. Now come to the labia majora. So for the labia majora, it's become very pigmented. Pigmented means like reddish kind of things you can see, as well as a hypertrophied, means blood accumulation, blood cell progression you can see in that particular phase. Now come to the perineum. So perineum is become enlarged, increase the vasculature, means vascular system is going to be increased, hypertrophy of the perineal body, especially the tissue, and then disposition of the fat. Now come to the vagina. So vaginal walls is become hypertrophied, hyperplasia, edematous and vascular, which is mainly helpful, which is mainly stimulating the increased blood supply surrounding the walls, which is giving the bluish discolorations of the anterior wall, especially of the vagina, which is known as a Jacquemin's sign. So these all are the changes of external reproductive organs. Now come to the breast. So in the early pregnancy, what is happen? You can feel the breast as a tingle, and it's increase in size when the pregnancy is gradually progress. The areola of the nipple is become very dark and pigmented, as well as diameter is also going to be increased, and Montgomery's glands is going to enlarge and tend to produce. So Montgomery glands are nothing but which is present surrounding of the nipples inside of the areola, but during this pregnancy journey what is happening is enlarging and it's creating a structure as like a goosebump. So that is called Montgomery's glands become enlarging. Okay, now the surface vessels of the breast may be visible due to increase the circulation system and turns to a bluish tint to the breast. So now come to the by 16th week of the pregnancy, what should be the change? The breast begins to produce the colostrum. Colostrum is a first milk which is tiny, watery, as well as the yellowish color, and it's a rich of the immunoglobulin which will be helpful to produce the immunity inside of the baby. This is the precautions of the milk. It is a thin watery yellowish secretion which thickens the pregnancy process, and it's extremely high in the protein. Now come to the changes of internal reproductive system. So for the uterus, what is happened? Uterus is phenomenal, and this uterus will have the increase 5 times in its normal size. Length from 6.5 to you can see up to 32 centimeter. Depth 2.5 to 22 centimeter. Width from 4 to 24 centimeter, and weight 500 to 1000 gram. And thickness of the wall should be 1 to 0.5 centimeter. So these all are the changes are happening lengthwise for the uterus, and this capacity of the uterus is also becoming more. Like at that time they can accommodate a 7 pound of the fetus and placenta, umbilical cord, 500 ml to 1000 ml of the amniotic fluid, as well as the fetal membranes. Means all the viable product of conception is going to be accumulated inside of the uterus. So now come to the uterine layers of the changes. So the layers are myometrium, endometrium, perimetrium. Okay, so now come to the myometrium. So what are the changes is happening? So myometrium, due to this the mechanism of the uterine enlargement, the myometrium is become so stretchful, and then hypertrophy of the muscle fibers, which is mainly helpful to increase in the elastic tissue and accumulations of the fibrous tissue in the external muscle fibers. So see the arrangement of the membranes, how it's going to be happen. In the outer longitudinal phase you can see arranged over the fundus. Inner circular you can see as a scanty and sphincter like structure. Intermediate you can see as a thickest and strongest layer which is crisscross in fashion. Okay, now come to the shape transformation. Early months of the pregnancy you can see the uterus as a pyriform shape as well as a pear shape. At the 12 weeks is become as a globular, and 28 weeks is become as a dome shape, and 36 weeks it's become as a ovoid in manner. So these all are the shape changes of the myometrium. So now come to the changes of the position. How it's going to change? Uterus, it started to growing, elevated up to 12 to 6 weeks of the pregnancy, and at that time you can palpate at the near of the symphysis pubis. So at the 22 to 24 weeks you can palpate the uterus, especially the fundus level at the level of umbilicus and near of the xiphoid sternum or the breastbone. So next, the size of the uterus is also reaches a peak up to the 38th week of the gestation. So the uterus may drop slightly at the fetal head settles into the pelvis, which is preparing for delivery, and this the settlement or the dropping down is known as a lightening. So the Braxton Hicks contraction also you can see, which is present in early pregnancy time. So uterine undergoes a spontaneous contraction which are irregular, infrequent, painless, without any kind of the cervical dilatation, and this pain you can see mainly from the front side of lower abdominal region to the back side of the pelvic. So these all are the changes of position. Now come to the endometrium. So during this pregnancy is known as a decidua. Okay, so this decidua is formed as a 3 layers. First is superficial compact layer, which mass of the decidual cells, gland ducts, and then dilated capillaries. Then intermediate spongy layer, it's the dilated uterine glands, decidual cells, and blood vessels you can see, and then thin basal layer you can see basal proportion of the glands, and which is opposed to the uterine muscle. So now come to the perimetrium. So in the perimetrium, you just remind, perimetrium is helpful to creating as a buccal holding fashion as well as the upper and lower segment of the uterus. So thin layer of the peritoneum which protect the uterus, inelastic base which actually doesn't cover the uterine bladder part. So it doesn't cover the uterus bladder part as a uterovesicular pouch, and the rectum part they are holding as like a pouch of Douglas. Now uterine blood flow you can see increasing progressively and reaches up to 500 milliliter per minute, and then formation of the lower uterine segment you can see after the 12 weeks the isthmus or 0.5 centimeter which start to expand gradually to from the lower uterine segment which is measured 10 centimeter in length at the top. Now come to the cervix. So cervix is nothing but it undergoes the softening period of time which is referred as a Goodell sign, and additional changes or softening cervix you can see at the beginning of the labor. A mucus plug which is known as a operculum. So it's you can see this mucus plug formation in the cervical canal which is result as a enlarged and active the mucus gland of the cervix. And also it serves to seal the uterus and protect the fetus as well as the fetal membranes from any kind of the infection. So this mucus plug is going to be expelled at the end of pregnancy. For the primary gravida, it's you can see the expulsion of the mucus plug during the labor, but for the multipara it's happening during onset of labor or else prior of the labor, and this may occur at the onset of labor and proceed for a few days. When the mucus is blood distinct, so that time is also known as a bloody show or the show presentation. Now come to the ovary. So what is happening? The FSH or follicle stimulating hormone which is ceases its activity due to this increased level of the estrogen and progesterone in the circulatory system which is started to secrete by the ovaries and corpus luteum. So this corpus luteum is also going to enlarging during early pregnancy, and it's also form a cyst type of the structure on the ovary. So this corpus luteum they are producing the progesterone which is mainly helpful to maintain the lining of the myometrium after the implantation, means in early pregnancy. So the function which lasts till 10 to 12 weeks of the pregnancy, because after 10 to 12 weeks of the pregnancy placenta is only taking all this action, means placenta started to produce estrogen and progesterone inside of the circulation system. So next at the time of the interval it start to decrease in the size and then function it slowly. So these all are the mechanism of the ovaries. Now come to the fallopian tube. So fallopian tube is nothing but like uterus is also started to rises up end, and then femoral end is also held up by the infundibulopelvic ligament which is placed almost the vertical by the side of the uterus. So what is happened due to this presentation, the increase in vascularity at term when it's going to be attached is lower end of the upper 1/3 of the uterine part. So now come to the changes in integumentary system or the skin. So due to this the hormonal balance alteration and then mechanism of the stretching which is mainly responsible for several changes for the skin. Okay, so what are the changes? Like linea nigra. Linea nigra is nothing but it's a dark line which you can see from the umbilicus to the symphysis pubis, might extend up to the xiphoid sternum, and it's a hormone induced pigmentation. After the delivery it started to begins to fade through, it may not over completely after pregnancy also. Now come to the mask of pregnancy or the chloasma. This is a brownish hyperpigmentation on the skin over the face you can see, and then forehead it also gives a bronze look like of the structure, especially for the dark complexion of women, and it started to produce around 16th week of the pregnancy journey and gradually increasing, then it's usually fade after delivery. Now come to the striatum gravidarum or stretch mark. So what is happened? This may be due to the attraction of the adrenocorticosteroids hormone. It reflects the separations with the underlying connective tissue fat of the skin, and it also occurs over areas of the maximal stretch like abdomen, thighs as well as the breast, and it's usually disappear after delivery, but sometimes it's not completely disappearing. Now come to the sweat glands. So sweat glands throughout the body, it started to increasing, which causes women to perspire during the pregnancy journey. So after doing some work, they are started to breathing difficulties. Now come to the hirsutism. This is a fine over hair growth you can see on the face side, and after the delivery it will be disappeared. Now come to the palmar erythema. It's nothing but it's a pinkish diffuse mottling well defined blotches you can see on the palm side, especially you can see for the 60% cases of the white woman. So now come to the changes in the circulatory system. So circulatory system is blood level, right? So blood volume is going to increase gradually 30 to 50%, like 1500 milliliter to 3 units, and which is result in the decreased concentration of the RBC, because producing excessive amount of the blood inside of the vein and the circulation system, what is happen, RBC concentration is going to be reduced, as well as the hemoglobin level is also going to be reduced. So what is happen, iron is one of the most important during pregnancy. Now come to the second point. By the time of the pregnancy reaches term, so the body of the human, the woman is usually compensated for the decrease resulting in essentially normal blood count, and then blood count is also going to be interpreted as anemia by the physician if the hemoglobin level is below 10.5 gram per 100 ml and hematocrit drops below should be 30%. Now come to the cardiac output. So cardiac output is also going to increase about the 30% cases, especially first and second trimester, which is mainly helpful to accommodate for the hypovolemia. So a patient with the heart disease, especially at a high risk to get the cardiac decompensation 28 to 35 weeks of the pregnancy, because the blood volume and then cardiac load at that time it should be in the peak level. So also during the labor time and immediately after delivery also there is a chance. So changes in the output, which is reflected in the heart rate, it usually increased by the 10 beats per minute. So now come to the blood pressure. So normally the blood pressure will not be rise. In spite of the large increase in the cardiac output, the maternal BP is equal to cardiac output into the SVR, or systematic vascular resistance, is due to decreased due to this increase in the SVR. So now come to the venous return. So the lower extremities, which is mainly hampered in the last month of pregnancy due to this expanding uterus. So the physical movement is going to be restricted, and it's also going to interfere with the return blood flow. So this result is swelling of the feet and legs. Now come to the WBC count. So what is happened? The total blood leukocyte count is going to increase during the pregnancy from 4,300 to 4,500 gram per milliliter to 5,000 to 12,000 per milliliter in the last trimester. Although sometimes the count of the WBC is going to be crossed as high as 16,000 per milliliter in the last trimester, come as a high 25,000 to 30,000 per milliliter for an abnormal patient during the labor time. Now come to the clotting factors. So clotting factors during pregnancy is going to be increased. The factors are following like factor 7, 9, 10 and 12. So now come to the position and size of the heart. So what is happened when the uterus is going to be enlarges, so the heart position as well as lungs position is going to be displaced upward and somewhat to the left with the rotation of the long axis. So what is happened, apex of the heart beat to move laterally, and this cardiac capacity is also going to be increased by the 70 to 80 milliliter, which may be due to increase the volume of the hypertrophy of the cardiac muscles. The size of the heart disappears in increase by about the 12%. Okay. Now come to the changes in the respiratory system. So first is we will say anatomic and physiologic changes. Okay. So early in the pregnancy, what is happened? The capillary dilation you can see throughout the respiratory tract, which is mainly leading to the engorgement of the nasopharynx, larynx, trachea and bronchi. So when the uterus is going to enlarging, the diaphragm is started to elevate it up to the 4 cm upwards, and ribcage is going to displaced upward and increasing the lower thoracic cavity or diameter or abdomen by by the 2 centimeter and thoracic circumference by up to the 6 centimeter. So now come to the lung volumes and capacity. So alterations you can see occur in the lung volume and capacity during the pregnancy. So it includes the following: the tidal volume, which increase gradually 35 to 50% as the pregnancy process, and total lung capacity is going to reduce 4 to 5% by elevation of the diaphragm. So functional residual capacity, residual volume and respirator reserve volume all is going to be decreased by 20%. So larger tidal volume and smaller residual volume, which is causes increase the alveolar ventilation about the 65% during pregnancy, and inspiratory capacity is also going to be increased nearly 5 to 10%. Now come to the changes in urinary system. So the kidney must work extra hard, which is excreting the mother's own waste product plus those of the fetus waste product. So the women, they started to develop urine stasis and then pyelonephritis. Urine stasis is nothing but like a less production or the stopping production of the urine, and pyelonephritis is nothing but it's a bacterial infections of the kidney of the mother. Mainly it's happened due to this pyelobacteria. So that's why is known as a pyelonephritis, especially in the right kidney. And frequent urination is a complaint during the first to third trimester because the excessive pressure is creating on the bladder due to expanding size of the fundus level of the uterus. Okay, so now come to the renal dilation. Dilatation is nothing but like each kidney they increased in the length about 1 to 1.5 centimeter. So the ureter is also started to dilate above the brim of the bony pelvis. So the ureter is also going to elongate it, widen and become more curved, and thus there is an increase in the urinary stasis, which may lead to the infection and may take rest of the renal function. Now come to the glomerular filtration rate. So what is happened? GFR rate is also going to increase during pregnancy by 50%. So the renal plasma flow rate is also going to increase as much as by 25 to 50%. So now come to the glycosuria. So during the pregnancy it is necessarily abnormal, which is explained by the increase in glomerular filtration rate with the impairment of the tubal absorption capacity of the filtered glucose. Now come to the proteinuria. So changes the little during pregnancy if more than 500 mg per 24 hours is going to lost, and the disease process should be suspected. So now come to the levels of enzyme relief. So renin, so which is produced in the kidney, and it's going to increase early in the first trimester, and it's also going to continue to until arise the term phase of pregnancy. Now come to the bladder. So when the uterus is going to enlarge, the uterine bladder is also going to displace upward, and it's become very flattened in the anterior posterior diameter. So pressure from the uterus is creating on side of the bladder, so which leads to increase in urinary frequency, means holding capacity is going to be decreased. So bladder vascularity increased and capacity up to 1500 milliliter. So now come to the changes in skeletal system. So what is happened? The realignment of the spinal curvature you can see during the pregnancy journey due to maintain the balance. So in this time, due to increase the size of uterus or pressure on the abdominal wall, the mother is bending like forward or backward to maintain the balance. The patient works with head and shoulder thrust backward, and chest they are following inward or the outward. Now this is a slight relaxation and increased mobility of the pelvic joint, which is mainly helpful for allowing the stretching at the time of delivery of the infant. Now come to the gastrointestinal system changes. So first come to the oral cavity. Salivation you can see might be increased due to swallowing difficulty, which is associated with the nausea, and if the pH of the oral cavity decrease, means tooth decay you can see for the mother. So the gums is also become hypertrophy, hyperemic and febrile, which may be due to increase in the systematic estrogen. So vitamin C deficiency also you can see, which can cause the tenderness and bleeding of the gums, and then gum is returned to the normal in the early puerperium period. So what are the complications? Gingivitis, pyogenic granuloma, salivary changes, tooth mobility, melasma and gingival hyperplasia. So now come to the gastrointestinal motility. So gastrointestinal motility is also started to reduce during pregnancy due to increased level of the progesterone, which is decrease the production of the motilin. So if the motilin hormone is not production is happening properly, so what will happen? From the food they will not able to produce the bolus, which will not be helpful for the digestion. So the transmit type of the food throughout the gastrointestinal tract is much be slower, and leads to the constipation. So now come to the stomach and esophagus. So gastric production of the hydrochloric acid is variable, and sometimes sometimes it's become exaggerated, then especially during the first trimester of period. So production of the hormone, especially the gastrin, which is increased significantly, resulting increase of stomach volume and decrease the stomach pH. So exophageal peristalsis, which is going to decrease, is accompanied by the gastric reflux because of the slower emptying time, which is leads to the heartburn. Now come to the small and large bowel. So the small and large bowels movement upwards and then laterally, the appendix is going to be displaced superiorly in the right flank area. So what is happened? Those organs return to the normal position in the early puerperium period. Now come to the gallbladder changes. It's altered during pregnancy because of the hypotonia of the smooth muscle bulb, and emptying time is also becoming slow, so often incomplete. So bile can become very thick and bile stasis may lead to the gallstone formations in the gallbladder. Okay, so now come to the liver. So there is no apparent morphological changes you can see for the liver during pregnancy, but there are the functional alteration, like serum alkaline phosphatase activity might be doubling, then probably because of the increased placental alkaline phosphatase isoenzyme. So these all are the changes is happening for gastrointestinal system. Now come to the changes in endocrine system. So first is the thyroid gland. So thyroid gland is increased in size due to increase in the iodine metabolism, and it's returned normal by the post-delivery period. So for the parathyroid gland, this gland is also increasing slightly in size, but it meets the increased requirements of the calcium needed, which is for the fetal growth. Next is the posterior pituitary gland. Near the end of the term, it will begin to secrete oxytocin that was produced by the hypothalamus. Now come to the anterior pituitary gland. At birth, it begin to secrete the prolactin. Mainly, it stimulates the production of the breast milk. So in this session, I discussed about the pregnancy and physiological changes of each and every systems of the pregnancy. I hope you all understood my session. Again, we will meet in next session. Till that, keep learning and stay tuned with us. So thank you so much.